What I was asked to talk is strictly about what to do when there is mild or moderate TR, so secondary TR, from a disease, main disease on the left side heart, mostly mitral, but it can be also applied to aortic. Now, the incidence of tricuspid regurgitation associated to left valve disease, is variable, but it can go from 8 to 35%, depending on your definition. In 80% of those cases, the valve is not abnormal. The TR is functional, is related to the right ventricle, its dilatation and dilatation of the annulus. Functional is a term that is no longer used. The guidelines use secondary to the left side valve disease. Especially in rheumatic cases, there are a number of cases. In rheumatic patients, there are a number of cases where the tricuspid valve lesion can be organic, and I will leave this aside from this presentation. Now, when I started surgery, we lived with this Nina Braunwald's theory of conservative management of tricuspid regurgitation. She said that in the majority of patients with secondary TR, surgical treatment of the mitral, at that time was just said mitral, but I added aortic disease corrects the problem of the right side. In such a way, it's like a side card, you know, the left ventricle always takes together the right ventricle, and the right ventricle cannot separate itself from the left ventricle. Now, what we know is that the results of surgery of the mitral valve are less favorable in patients with associated right heart disease, that right ventricular disease with significant involvement of the tricuspid valve represents advanced disease that has a decisive effect on the natural history and evolution after surgery, that even when mitral valve surgery has long-term success, in many cases there is progressive increase in the tricuspid regurgitation. And this happens because functional right tricuspid regurgitation, sorry for that, with severe annular dilatation can cause irreversible deterioration of the RV function. So it is both a consequence and cause of dysfunction of the RV. A long clinical course can cause further clinical and hemodynamic deterioration of the right ventricle, therefore increasing surgical risk. So when you think about the tricuspid valve in this situation, and I stress again, this situation, mainly you go for left heart valve, mitral or aortic, and you have a degree of tricuspid regurgitation, and I'm not going to discuss severe tricuspid regurgitation because we all know that in that case you have to intervene. So why, when, and what, and how? And this all changed a little bit. It changed much when Jill Dreyfus published this paper some decade and a half ago almost, secondary tricuspid regurgitation or dilatation, which should be the criteria for surgical repair. Because in their work, having measured intraoperatively the size of the tricuspid annulus in this direction with a ruler, the authors concluded that secondary tricuspid dilatation is present in a significant number of patients with severe mitral regurgitation and without tricuspid regurgitation. So you have dilatation with no tricuspid regurgitation. It is a progressive disease which does not resolve with correction of the primary lesion alone, and therefore tricuspid annuloplasty at the time of mitral valve surgery in this patient results in improved functional capacity without increasing perioperative morbidity and mortality. I also say that, but you must remember that even when it's stopped at a red sign, the taximeter is always counting. So we mustn't be fooled by the fact that you say if you only had 5 minutes on cross clamp and 5 minutes and 10 minutes in cardiopulmonary bypass, it's safe. Nothing of what we do is absolutely safe and in it. But it adds very little to these things. Now, Professor Barlow was mentioned already a couple of times today here and in the other room. In his book, which was shown by someone earlier this morning, written in 1987, so long before Dreyfus' paper, he said that it is probable that this lesion, tricuspid regurgitation, is often partly or mainly organic. It's not just a question of dilatation of the ventricle. It's not just a question of dilatation of the annulus. It can be. But more important than this, he already said prophylactic annuloplasty. And I was fortunate to have worked with Professor Ballo as my senior cardiologist for 14 years. First as a registrar, and then as a surgeon, then as a senior surgeon, and as the chief surgeon. And every time I had, but we're talking about 35 years ago, that I didn't touch the tricuspid valve, it came on me. He was a difficult guy to know, excellent cardiologist. So he did claim for prophylactic tricuspid annuloplasty in all patients. And at that time we did not have echocardiography measurements of the aortic annulus. So that's what he claimed for. Now, just before he died, I wrote it in Heart, this paper, Management of Tricuspid Valve Regurgitation, and it's the last work that he published, and I'm very happy that my name was associated. I wrote most of it, but he reviewed it. Following Dreyfus' papers, there were several papers that confirmed that if you did something to the tricuspid valve when there was only mild or moderate regurgitation, the patients did better. There was, this is Robert Dion's team, concomitant tricuspid annuloplasty during mitral valve repair should be considered in patients with tricuspid annular dilatation, despite the absence of important tricuspid regurgitation at baseline, because this improves echocardiographic outcome. But this was just echocardiographic. And there is up to now no study that shows that there is a difference in survival or freedom from reoperation in the long term. We know that regurgitation does appear, but it seems to be reasonably well limited and controlled by medical treatment. And Calafiore and his colleagues also mentioned that an aggressive strategy for functional tricuspid regurgitation correction using the systolic tricuspid annular diameter was able to reduce functional tricuspid regurgitation grade 1 year after surgery, but mitral surgery alone could not. So there appears to be an advantage of doing something to the tricuspid valve. Nothing up to now, I couldn't find any work that confirms that if there is no regurgitation, you should still do an annuloplasty. But maybe one day will come. And for this reason, and for these works, the guidelines, the recent guidelines say that, considered it as a class 2A, but they don't go to a class 1A. In fact, because I was working with it as well in the previous version. Surgery should be considered in patients with mild or moderate secondary TR with dilated annulus, greater than 40 millimeters or 21 millimeters per meter square, undergoing left-sided valve surgery. Now, already in this room now, in the other room, this morning I said, you know, we keep talking and asking about the guidelines, and the guidelines are out of there. And those who have worked in guidelines know how much work, how much discussion is there. And usually all what is written in the guidelines is obtained by consensus of a large team of specialists, and this included in cardiologists and surgeons. And in the end, you know, people don't go for it because it says if there is mild to moderate tricuspid regurgitation, you should do something to the tricuspid valve. Now, the problem is that there are a couple of figures here, 40 millimeters and 21 millimeters per meter square, and we don't know where did they come from. I don't know any paper who says exactly this. In fact, this study, which is measured healthy volunteers, echocardiographically, you can see how much variance there is in the size of the tricuspid annulus and into the indexed tricuspid annulus diameter. And therefore, there are normal patients that go beyond the 40 millimeters and that go well beyond the 21 millimeters per meter square. So we don't know exactly where we are right now, but we know quite a few things. Those who have been at the AATS meeting last year would have assisted to, and also the mitral conclave before that, the discussion between David Adams and Tyron David. David Adams does tricuspid annuloplasty in 80% of his mitral valve patients, and Tyron David in 20%. And he says that one says that you're doing too little, the other one says that we do too much. And Tyron David has just published, it's come up online a couple of weeks ago, this paper, Tricuspid annulus diameter does not predict the development of tricuspid regurgitation after mitral valve repair for mitral regurgitation due to degenerative diseases. Again, rheumatic mitral valves may be a little bit different because of what Valo says, that there may be that there is also organic disease in this setup. They used the 40 millimeters, and in their experience, they did not find any evolution of the disease, of the tricuspid disease after that. The working groups of cardiovascular surgery and valvular heart disease have joined together, organized a task force. I was the organizer. Published recently in November last year in the European Journal this position statement on management of tricuspid valve regurgitation. And again, we don't say anything much, but is, to my knowledge, one first paper organized by him. Its guidelines have 2 paragraphs and one table on the management of tricuspid regurgitation, and we go a little bit further than that, and we established this scheme about what to do, and I'm not going to dwell on it because it's too complex and we have little time. Anyway, there are still some controversies in tricuspid surgery. The first was already mentioned today, is the choice between annuloplasty and replacement. Now, in my view, in this setup, replacement when the valve is destroyed, when there is organic, replacement when the dysfunction of the right ventricle is very severe, because otherwise you can't really repair the tricuspid valve. There is no place for replacement, but I'm talking about just this setup. And then I want to just mention a couple of things about the methods of annuloplasty, and in case of replacement, the choice of prosthesis. Now, annuloplasty can follow several lines. Initially were sutures. Bicuspidization was the first one, and then came the Vega suture, and then the rings, bands, rigid, flexible, and so on. Now, one tends to ignore, one tends to forget the past. And bicuspidization was abandoned completely because it just deals with the limited segment of the tricuspid annulus, as you see in here. Yet Cohn's group, Lawrence Cohn's group, a decade ago, published this paper saying that suture bicuspidization of the tricuspid valve versus ring annuloplasty, or analyzed this for repair of functional tricuspid regurgitation in 237 consecutive patients. And they, in fact, came up with better results of the annuloplasty than with the ring, on suture annuloplasty than with the ring. Now, you'll find, you are aware of this work from the initial group of Carpentier, showing exactly where does the tricuspid annulus dilate. And it goes from both commissures between the septal leaflet and the anterior and posterior leaflets. And that's that area of the annulus that we have to deal with, and that's exactly what the ring does. The ring does that, and goes, and it goes to the middle of the septal leaflet. And that's an important point, as I will discuss a little bit later. Now, the Vega suture annuloplasty came out almost at the same time. It goes from both commissures, exactly what that scheme of the annular dilatation did, but frequently dilatation occurs at this level. That's where the K suture was utilized before, where the bicuspidization works. Now, one of the problems with the Vega procedure was the was the essence of the suture, creating the so-called guitar string syndrome. But anyway, there are several papers showing that ring is better, as this one. Placement of an annuloplasty ring in patients undergoing tricuspid valve repair is associated with improved survival and event-free survival. The differences aren't really greater, but we are all persecuted by the question of statistical significance. A couple of numbers after a comma, or figures after a comma, that show that this is very significant. In fact, I would prefer to be here than in here, or be there than in here, if it was the case. But others show that, in fact, this is not the case. This study, and that's a long-term study in 300 patients, reported better results with the conventional, the Vega suture annuloplasty compared with ring annuloplasty. And this analysis, this meta-analysis of several studies showed one cohort showing that ring annuloplasty was had the lowest rate of occurrence. They reviewed one recent study showing exactly the contrary, and then they reviewed another study, two other studies that showed that there was no difference. Now, again, here is one of my own figures, photographs of guitar string syndrome, and you can see that that was the problem. And for that reason, initially, back in 1987, I and a co-author published this little modification. I don't call it any other name, but modified the Vega annuloplasty, which interposed Teflon plates to avoid the dehiscence of the sutures. Well, we again have found that it is fast, it's technically simple. You can do this in about 7 or 8 minutes and avoids this type of complications. Now, this is one of my own cases, later requiring heart transplantation, and you can see how dilated it is. And the reason is that because this commissure, this region between the commissure and between the septal and the posterior leaflet is not protected. So we have modified our modified procedure to go to the middle of the septal leaflet the same way as the ring does. And I think that this makes the difference between a suture and a ring. Because the ring always, or the band always covers that portion of the septal leaflet, and that is quite important in my view. Now, this paper from Fred Moore's center in Leipzig shows that although both rigid and flexible systems provide acceptable early tricuspid valve repair results, use of a rigid ring increases the risk of subsequent ring dehiscence. If you go back to this after a couple of years, the fibrosis and the ingrowth of endocardium that goes over that makes it a flexible blend after that. So while in the mitral valve, I'm really a fan of rigid rings. In the tricuspid valve, I think that the functioning of the right ventricle probably favors the use of flexible structures, a ring or this type of thing. So the implantation of a ring, in my view, is specifically indicated when there is organic involvement of the tricuspid valve, usually with stenosis, where commissurotomy is also necessary. And in conclusion, secondary tricuspid dilatation is present in a significant number of patients with severe mitral regurgitation. It is a progressive disease which does not resolve with the correction of the primary lesion, that means left side valve alone. Tricuspid annuloplasty at the time of mitral valve surgery results in improvement of the functional capacity without any increase in perioperative mortality and morbidity. On the contrary. And finally, functional TR can only be ignored in patients with predictable and significant reduction in pulmonary resistance. And the quality of the repair of the left side valvulopathy appears fundamental to avoid late tricuspid regurgitation. And that's all. Thank you very much.